So we begin. We have Boris Gorkovsky. Co-presenter is neurosurgeon Lahina. And the name of the presentation, Strategy of the Perifocal Zone of Glioblastoma. Distinguished Presidium and colleagues, I'll do my best to tell you about the current problems regarding the issue. Glioblastoma, disregarding its low frequency, is nevertheless the most frequent brain tumor in adults and has a bad forecast. The life duration is a maximum 1.5 years. That's the survival, while glioblastoma treatment is very complex, and besides radiotherapy, it includes chemotherapy. One should mention that more than half of glioblastomas are resistant to the first-line therapy with temozolomide agents. Thus, one of the main principles of surgical treatment of glioblastoma and any other malignant tumors is radical resection. In this case, it's very difficult to achieve it, since even experienced neurosurgeons with white line, white light is difficult for them to find the borderline of the tumor. So, to plan the surgery correctly and to determine the volume of resection, additional methods were created. Some are instrumental studies, and some are infra-operational fluorescent navigation. So, what do we use? First of all, one of the most important tools is MRI, especially with additional modes of suppression of free liquid with a flare. There's differential diagnosis. They specify the localization and the borders of the tumor. There's also PET, and it enables us to see the metabolism with stained radiopharm preparation. First of all, amino acids are used. Besides, glucose may be used. What do we get if we combine the methods? Methodology improves, so do technologies. Thus, we have different understanding about the size and the borders of the tumor. First, FLAIR image provides just the edema of a brain, and mixed tumor infiltration. The area is pretty large. However, if we use contrasting amplification, then the tumor is smaller. The borders are much smaller. But if we use PET MRI with stained amino acids, you see a metabolism with bright zones. Thus, we can understand the real borders of the tumor. And if we combine the results of 3 images, we can determine the actual size of the tumor. Also, there are zones of glioblastoma that do not accumulate contrast agent. So, how do we determine during the surgery? You can use aminoleurin acid. It's a non-toxic acid that patients take orally before surgery. One of the metabolism agents is proliferanin 9. This substance accumulates in glioblastoma cells. Only thus, in the blue light during the surgery, the neurosurgeon may see bright red light in the center of the tumor and pink along its perifocal border. It should be mentioned that normal tissues of brain do not accumulate this acid, and thus in blue light they look below. Thus makes it easy to do navigation during the surgery. Topical issues left. In gray zone, there's precise morphology, content of the perifocal zone, its biopotential, and its role in the treatment of glioblastoma patients. It is still not clear how it influences the forecast and the treatment. The Refocal Zone, according to the latest study, includes not only the tumor cells, but also the surrounding micro and microglia and other. They produce cytokines, growth factors that ease the growth of tumor in this zone. So the micro-surrounding cells form a border niche, according to some authors. And hematoxis attracts to the zone the stem cells of the tumor, providing its invasive and fast growth. And a genetic study of the microRNA, the population of these cells is rather heterogeneous, and it's not the same cells as those of tumor. The other structure, perifocal zone, may proliferate into the normal tissue of brain. Thus, it's difficult to say how structural and functionally intact this area is. Because if functional areas of brain are impacted, the neurophysiology of patients suffers. Glioblastoma exist that do not accumulate the contrast, and there are the contrast non-accumulating zones in glioblastomas. They exist, while the number of live tumor cells in these zones is much higher than in the other areas. And if we remove the zones, that's good for the survival of the patients. So a big study was conducted. They studied a bigger resection of the contrast non-accumulating zones as well. The result is that in that case, there are less complications, and the patient survival is 1/3 higher than in smaller volume of resection. The obtained results coincided with the results of our colleagues of Palinov Institute. They had a selection of 59 patients, and glioblastoma without contrast non-accumulating zones has better forecast than the glioblastomas with such zones that do not accumulate contrast. Moreover, of importance is the interaction of non-impacted brain tissue and the perifocal part of glioblastoma. The micro-surrounding of the tumor cells may interact with the functional centers' neuron networks, and this will provoke the future growth of glioblastoma into the important parts and functional parts of the patient's brain. Hence the question, the practical importance. If it's difficult to remove these areas surgically because they have occupied the important functional centers, maybe there are other ways to impact the tumor and its growth parts. The good target for the development of target therapy are the transcription factors, proteins, transcriptors, and genes. Let's allocate in GMT the protein responsible for DNA reparation and for the glioblastoma resistance to the first-line drugs. Quiparamin, the transcription factor that provides metabolism of the tumor cells in conditions of hypoxia and their survival. The factors of neurogenesis development one because it's lost in glioblastoma, but the reverse factor makes it mature and reduction. And peroxidin, another factor, participating in differentiation of neuroblasts. It's very sensitive prognostic marker, which is determined in malignant glial tumors only. Foxamadin is a very different functional factor of transcription responsible for angiogenesis and for the DNA reparation and for the resistance of glioblastoma to the radio and chemotherapy. TFC4 is the membrane receptor. It forms the microvascular surrounding in normal brains of cerebral tissue and protects from radio chemotherapy and provides its stem properties. Receptor of type 2 and 3, they were recently actively studied for diagnosis and treatment of neuroendocrine tumors. There's a lot of marked agonist and antagonist, and this may be used for target treatment of glial tumors as well. Pathomorphology Research Institute has performed a study for glioblastoma with 10 samples from patients with glioblastoma from the tumor and from the perifocal area. And each patient received before the surgery amino acid to ease the navigation. And during the surgery, they took samples at the border of pink fluorescence and normal brain tissue, and from the tumor itself, according to the adopted protocols. The histology presents that the morphology of the focal zone may vary from normal brain tissue to diffuse stressitoma zones and to the zones of obvious growth of glioblastoma. The analysis of transcription factors was performed brown staining of nuclei, and in perifocal zone and in the glioblastoma, C4 was found receptor somatostatin, Kievanin, and Ki67. Well, of interest are the markers Ki67. It's used for grading and diagnosis of brain tumors, and FOXM1, one of the key genes of oncogenesis of malignant gliomas. Gliomas can't exist without it. Well, we discovered the following. Ki67 is varied a lot in perifocal zone according to its histology structure, and the properties were different. Proliferative activity was sometimes up to the level in glioblastoma, but the expression level of FOXM1 stayed high both in tumor and in perifocal area. Hence, it's oncogenic. Now the scanning microscopy of fluorescence of photoproliferin 9. Let me remember, it only accumulates in malignant glioma cells. And we discovered luminescence is present in perifocal zone and in its vessels too. Protoporphyrin accumulates near the cell nuclei. And to confirm its intracell localization, we've made an additional standard with mitochondria tracker. It's green, and nuclear are blue. Protoporphyrin is red. So we have localization of the signal of protoporphyrin 9, and mitochondria, it's yellow light. This confirms the presence of oncogenic tumor cells in perifocal zone of glioblastoma. In conclusion, let me tell that the main tragedy of or the main trouble of this area is that it actively interacts with the normal brain tissues and provides the invasive growth of a tumor. Quite often, it impacts the active functional areas that can't be removed with surgery and forms its radio and chemo resistance. One should hope that the development of new methods of target therapy on top of the standard methods is promising. We hope for inhibitors FOXM1 and photodynamic therapy with the usage of 5-ALK. That will improve the forecasting and non-relapse period of patients and survival. Thank you, Boris. Any questions? I have a question. Boris, in your center, did you try to treat with FOXM1, that glioblastoma? If yes, then how? In our center, we conducted several observations of a kind, but there's a bit of a problem. Inhibitor FOXM1, a proteasomide which we use, has no official indications for the usage against glioblastoma. So sometimes, upon the agreement, upon the consent of the patient, in a hopeless situation and after the doctor's consensus, we did prescribe inhibitor FOXM1 off-label. Not according to the indications, but it's the last line of experimental therapy, despair therapy. We have several observations of it, and luckily, the result is pretty optimistic. Survival of such a patient went up to 2.5 years. This doesn't coincide with the global literature data, with our experience. Really, if we add in FOXM1 inhibitor, that improves the survival period in such patients. We're now following up one of the patients, and in 2.5 years, there was no tumor relapse registered. I mean, of glioblastoma, but diffuse straticytoma was found in that area. And this requires more studies in a bigger group of patients. Let me comment. Third phase of study of proteasomine is finished for patients with glioblastomas, and I hope quite soon the results shall be published. While in Russia, there's a doctor's thesis published in Rostov. Immunocompetent mice were getting the patient's glioblastoma, and they were treated. And they proved that temozolomide with bartonelbabe is a good combination. Then results are okay. There is some improvement. However, in general, I'm a surgeon and I don't believe in all this, frankly speaking. As one famous neurobiologist said, the best that we can do with the tumor is to remove all of it. All the rest is just manipulations. However, it's all very interesting, and these methods are actively used for the patients. And some of the patients were really assisted. But if you have patients with glioblastoma, you do really treat them. No matter what you treat them with, they will live longer. That's what is observed as well. Any more questions from the colleagues? May I? No. Okay. Thank you very much. Though I'm not an expert in the field at all I can do is trust Borisov and Metrova thylacytes in the heart and in the brain. What's common between them? Soon they will prove that brain is a muscle. We had to find something common between heart and brain. And from the point of view of fundamental science, and today's presentations are in the field of fundamental science. The cells were discovered yet in 1893 by Alcohol. He thought these are interstitial neurons. These cells are responsible for contraction of GIT, gastrointestinal tract. They're also responsible for childbirth, since they are responsible for the uterus movements. And later, their presence was proved with electronic microscopy. They are called telecites. Why such a funny name? These are amazing cells with a body and a nucleus body and long telopodias. They stretch to all the structures in any tissue and any organ. Besides, there are dilated segments, the podoms of telopodias. And telecites are the cells that were recently discovered and proved they are muscular, nervous, stem, etc., etc. They're expressed into CD34, SMA, S100, NSE, and the main point, connexin 43. And as for connexin 43, that's the intracellular protein, double junctions. Now let's get closer to the heart. Such contacts are multiple in heart, and they enable to conduct the electric impulse. They're like the conductors of relations between the cells. They have pacemaker activity. That's one of the functions. They express different inflammation mediators, angiogenesis factors. They were found in all the organs, including the heart ventricles. As for the brain, Popescu found them in heart-brain cover and in the vascular nodes. Now, telecites in the heart, they participate in isolated amyloidogenesis. If they're implanted into the infarction zone and into the border zone, then the infarction gets smaller. There takes place active regeneration. One more thing, they were suspected, those cells, in arrhythmias, to cause arrhythmias, and Sava Kostin thought that since telecites are absent in areas with heart fibrosis, then the intracellular relations in myocardium are worsened, hence there's arrhythmia. That's the first stage of our study. We thought if telecites represent a kind of a glia of a kind, so that it's clear for neurosurgeons, it's a glia in any organ. Maybe they are present in sinoatrial node as well, in the sinus node of the heart. Maybe they are there. Seems illogical. On one hand, they're everywhere, but on the other hand, in the sinoatrial node, there are own life cells, pacemakers, the own conductivity system for the electric impulse. And this makes the person live. We took 15 patients, followed them up, studied them, found the sinus node. It's quite a laborious process. That's the way it looks. It's a sandwich principle. It's so that it doesn't contact anything. That's a lipid tissue, fibrous tissue, and inside it there are small life cells that provide the contraction and the generation of an electric impulse. They're small, 5 or 6 microns. Then there are the transition cells. Their function is to conduct the electric impulse from pacemaker cells to the working myocardium. And finally, the Purkinje cells. So we stained this with a special cunning marker, difficult to work with. This is the ion channel protein. That testifies that the conduction system of the heart cells may generate electric impulse. Then we did double marking or staining and saw our favorite telecites. That's the double marker, CD34 and connexin 43. On this micro picture, we observe the telecites, and with its telopodias, it embraces the cluster consisting of 2 pacemaker cells. That's the contact of the telecites with the muscular fibers of the myocard, working myocard. Then we were surprised to find out that telecites do contain that ion channel protein. Hence, there's a possibility to generate an electric impulse. Next, After the confocal laser microscopy, CD117 was conducted by us to double proof that these are really the telecites. And then we did the 3D reconstruction, got convinced that they form such a thick, active 3D network in the sinus node. Next, we checked whether the immune phenotype coincides with the classical telecites in the other organs. Yes, they coincide. It's a double branch of vimentin 100 co-expression of orange and yellow colors. CD34S100 co-expression of the orange color. Then we got convinced that, yes, true, these are telecites. And finally, the last level, electronic microscopy. In the sinus node, there are telecites. These are the telepodias, these are the podoms. And, surprise, they are even under the basal membrane of a pacemaker cells. That's where they are found. And in fact, it's they who conduct the transfer of the electric impulse from pacemaker cells to the working myocardium. That's of importance. Moreover, we couldn't believe ourselves, but we've conducted the last level of evidence. We found the proof with the help of the immunohistochemical analysis with the golden marker. We found H74 inside the telecites. Really, we did. Okay, we have the morphology proof evidence, but now we wanted electrophysiology evidence. We do remember that arrhythmia, the most popular is the atrial fibrillation. We took 10 patients with it, 10 with paroxysm form, 10 with permanent continuous form, and we check the crystal terminalis. That's the route of the electric impulse that it makes from the sinus node to the atrioventricular node. Thus, we found in a working atrial myocardium, a crystal terminalis is already in the working myocard of the atrium. We found telecites over there, and we did confocal microscopy. They have same properties as the telecites of the sinus node and as the other organs telecites, but we made one more step forward. We've grown the culture and proved that these are the telecites. Most important thing, patients without atrial fibrillation have 4 times more telecites than the patients with atrial fibrillation. We found out that there's a strong negative correlation between the number of telecites and AF, fibrosis, fatty tissue, and inflammation. In the heart, the telecites are welcome. They are good for the heart. In the right atrium myocardium, the average number of telecites is twice as small in case of AF. Permanent AF 6 times lower than in the sinus nodes, but these telecites are of the same immune phenotype. Now, electrophysiological properties. This time, we took the atrioventricular node. Those were the recipients' hearts at heart transplantation. And we also took the porcine hearts. They're easier to grow cultures on after the animals were killed in the experiment. The experiment was for a different medical purpose, pulmonary artery hypertension. We found the atrioventricular node. That's what the compact zone of the atrioventricular node looks like. There's a central arteria. That's a culture. It grew very well. CD117 proved that there's actual growth of telecites from the node. Then we fixed the pitch clump method calcium flow. Can't switch the slides, sorry. Potassium flow, sorry. And that wasn't insufficient for us to just make sure there's potassium flow. We moved towards calcium facylation, and in the native culture, we really found the calcium acylatations of telecites with mitochondrial potential. The analysis of the signals obtained enabled us to understand several stages before the death of the cell. At the first stage, due to calcium concentration increase, the mitochondria started to work more intensively. Then the natrium channels were left. We proved that they do exist in telecites.
We did confocal microscopy with 2 marks, double marks, and antigen natrium channels. You see how many channels were there, and so we proved that atrium ventricular node of the person and pig have telecites, and they have proved the presence of natrium channels. This is as far as heart is concerned. We thought that telecites exist only in muscular tissues, and then we had a massive morphological study of telecites, and we studied all parts of the brain, and we found them in vascular nodes and in cortex, less than 1%, subcortical nodules more, and in other places such as hippocampus more, and the biggest amount was in the cortex of the little brain. And the telecites of the brain had the neurogenesis that wasn't present in telecites of the heart. It's a factor that regulates the development of the central neural system as a whole. This is the quantity of telecites, CD117. So in then we were thinking, what is the role of telecites in glioblastoma? So we asked neurosurgeons to give us glioblastoma for analysis. In literature, so before we had studies in basilioma. So there was a Kaplan, a researcher, who discovered a stem cell, and while molecular biology and histochemistry, etc., were developing, in 20 years he had a conclusion that the stem cell is a pericyte at that moment. Pericyte is a cell that contacts, makes contacts of vessels with other tissues, and more of them are located in the brain, and they perform the same function as telecites. So we thought that maybe it's not pericytes but telecites, but pericyte is of different immune phenotype, and it doesn't express connexin 43 and expresses other things. We took 15 glioblastomas, 10 hemispheric tumors, etc., and we proved that pericytes are present in glioblastoma. In the recent years, we have determined the 5th type of glioblastoma. It's a marker of NG2. We use this marker to show double histoimmune coloring, that telecites, glioblastocytes are pericytes actually, but telecites are in vessels, in glial scar and in other cells, even in between cells. And in our culture, we discovered that we have telocides of glioblastoma can transmit the electricity. And we discovered one more mixed immunotype. It's a mixed type. So this image, I like it a lot because it shows how strong the vessels of glioblastoma are. Electronic microscopy demonstrated us the presence of pericytes and telocides, both of them. So you saw telocide when I pointed. And it turned out that glioblastoma, the quantity of telocides increases by dozens of times the telocides in normal tissues or in the brain in general. Immune phenotype of telocides in the brain corresponds to immunophenotype of telocides in all other organs, but it differs from immune phenotype of the heart by the presence of expression NERO-D1. We discovered four phenotypes: pericytes, telocides, immunophenotype, etc. And the origin of telocides and their interaction with pericytes and other tissues will help us to improve the therapy and even cell therapy. Is the presence of telocides and glioblastomas good or bad? In the heart, they help, but in the brain, do they help or not? In the tumor, what is the impact? So we addressed clinical studies, and I will start from, so do telocides call tumors? Yeah, it's a famous gastroenteral tumor. The telocides are its origin. Anti-KIT was a drug. It's an inhibitor of CD117, and it was surprising that this drug is really good when treating leukosis. And numerous clinical studies that have undergone 3 stages of this drug and its analogs show that it has negative impact on patients with glioblastoma. On the one hand, it needs to destroy telocides in glioblastoma. On the other hand, and it's good. And the effect of captation, let's not ignore it. In glioblastoma, captation is very close contacts of vessels with cells of the tumor. When we destroy telocides, we give impulse to the cells of the tumor to migrate. That's why it is bad, this drug, for treatment of glioblastoma. Thank you very much for attention. I thank my colleagues for active participation in this topic, this scientific issue. Thank you very much. Huge number of issues emerge after this report. If you speak about telocides and pericytes, if those are one of the possibilities to transmit the impulse of animal electricity, it's interesting. What is their role or information of Fauci of the tumors in the brain? Of course, it's a very complicated picture. It's of course not just transmission in the cables. Yeah, it's a famous thing. So it's more complicated than just electricity. So the meaning of these cells and transmission of agents in the tumor, and also in patients with tumors and epilepsy. I think they have the impact. Soon we'll have studies of telocytes in patients with epilepsy. But if we have hippocampus, we will study them if we are sure. If we make analogy with the heart, compare it with the heart, when we have cortex of the foci, we find the foci of micro. So we know very little about these cells. I think they take part in formation of central neural system because they are very ancient cells, and they might be stem cells in the brain. So first it's 3D network, and then there are cells of the organs that grow. The alveolocytes, for example, they are really simple and they do not need any special environment, but it's a very simple environment that they need. These cells grow very quickly. This story is even more simple. Each of the diseases is going back to one step to the level of functioning. So it's nothing new. Maybe the tumor is it's easier for it to provide itself with everything with more ancient and simple mechanisms. Thank you very much. It was really nice to listen to you, as always. So now we'll have our colleagues dear colleagues. So Sava's report, is it going to be demonstrated today as a recording, as a video? Yeah. Okay, let's see it. We were looking forward to seeing it. Добрый день всем. Меня зовут Сава Райчевич. Я работаю в отделе патологии в клиническом центре в Сербии, в Белграде. Я сегодня дам краткий обзор разных патологий, которые вызывают эпилепсию. Каковы эти патологии? Вот данные консультативного центра с прошлого года. Там было всего 6747 пациентов, и они были обследованы с точки зрения гистопатологий. Почти 30%, третья часть, это были опухоли. Это были состояния склероз гиппокампа, а также опухоли и неправильное развитие, кортикальное развитие, дисплазия, кортикальная дисплазия. Это 80% пациентов. И эти нарушения, может быть, также сосудистыми, также могут быть глиальные рубцы, энцефалит, а также может не быть никаких видимых нарушений. Склероз гиппокампа – это наиболее частый вид нарушений, которые встречаются. С точки зрения гистопатологии, он ассоциируется с реактивным астроглиозисом, А обычно он встречается в секторе CA1, это сектор Зомера, в секторе CA3 и в секторе CA4, сектор Братца.
See the anatomy of a human hippocampus. This is a mid-body section in the coronal plane, and we can appreciate the subiculum, CA1 region, CA2 region, CA3 region, and CA4 region, and this is the granular neurons of the dentate gyrus. The first classification of hippocampal sclerosis was made by Weiler in the 90s, and it was a quantitative one. In mid-2000, Sigmar Blumke made a qualitative classification, which the International League Against Epilepsy slightly modified in 2013, and it is the currently most used one. It classifies hippocampal sclerosis into 4 types, based on the sector of hippocampus with the most pronounced neuronal cell loss. In hippocampal sclerosis type 1, the pyramidal cell loss is mostly seen in CA1 and CA3-4 with or without CA2 involvement. We always see reactive gliosis, and this is the most common type. In hippocampal sclerosis type 2, pyramidal cell loss is mostly seen in CA1 with sparing of the other sectors. This is called atypical sclerosis. In hippocampal sclerosis type 3, moderate pyramidal cell loss is seen in sectors CA1, 2, and 3, and most severe loss in CA4. It is called the end volume sclerosis. And the 4th category is no HS, when the pathologist cannot see significant neuronal cell loss and only sees reactive gliosis. So histologically, it looks like this. We see the subiculum and the most pyramidal cell loss in the CA1 region and CA3-4 regions, and sometimes it evolves, as we said, a CA2, and it is a total hippocampal sclerosis. Hippocampal sclerosis type 2 is mostly centered on CA1 with relative sparing of the other sectors. Hippocampal sclerosis type 3 is mostly pronounced in CA4 with less neuronal loss in the other sectors of the hippocampus. And hippocampal sclerosis type 4, we cannot see by a naked eye without counting the neurons, the neuronal cell loss, and it is estimated that it needs to be about 25 to 30% neuronal cell loss, so the pathologist eye can appreciate it without counting. So no HS is the category of this mild hippocampal sclerosis. In our series of 167 patients with focal pharmacoresistant epilepsy that were operated in the Clinic for Neurosurgery of the Clinical Center of Serbia in Belgrade from October 2010 to October 2020, 92 patients, 55.1%, were diagnosed with hippocampal sclerosis, 82 were isolated, and 10 associated with other lesions in dual pathology we mentioned earlier. And the types of hippocampal sclerosis were as follows. The most common was, expectedly, 65 cases of 70% was the HS type 1, type 2 was 20%, and the rest was in much lower percentage. 3 cases, or 3.3%, were undetermined histologically because the tissue was submitted fragmented and the location of the hippocampal sclerosis could not be precisely diagnosed. Malformations of cortical development are the other big category of lesions seen in patients with focal pharmacoresistant epilepsy that are candidates for surgical treatment. This term covers a wide spectrum of developmental anomalies in the cortex that have different pathogenesis. They arise in the prenatal, perinatal, and early postnatal period and are a consequence of disorders in the mechanisms involved with cortical development, like apoptosis, migration of neuronal precursors, their maturation, and organization. The most common malformation of cortical development seen in surgical material is focal cortical dysplasia, and we will talk about it a little more. A quick reminder of the histology of human neocortex. It has 6 layers: molecular layer, outer granular, outer pyramidal, inner granular, and inner pyramidal, and the polymorphic layer. The cellular components beside neurons are inconspicuous. There is a sharp white matter to cortex boundary. It is the picture we see on the left. In a case of FCD, on the right, the cortex lacks the normal laminar organization. It is always disorganized, and the white matter to cortex boundary is blurred. In some cases, there are also cytological abnormalities in the form of dysmorphic neurons and balloon cells. This plastic cortex always shows some degree of reactive astrogliosis, so we can see reactive astrocytes. The first classification of FCD was the Palmini one in the early 2000s. The International League Against Epilepsy refined and upgraded the Palmini classification in 2011, and it is the currently most used one. Type 1 and Type 2 are the forms of isolated focal cortical dysplasia and were present in the Palmini classification, but ILE added the Type 3 cortical dysplasia associated with another principal, epileptogenic lesions. Type 1 has 3 subcategories, Type 2, 2, and Type 3 has 4 subcategories. So we'll talk about them a little more. Focal cortical dysplasia type 1, it has, as I said, 3 subtypes. 1A, we see abnormal radial migration and neuronal maturation stoppage with the immature small diameter neurons organized into microcolumns. In 1B, we see abnormal cortical layering affecting the 6th layer, the tangential organization of the neocortex. And the type 1C is combination of the 2A and B, so we have abnormal cortical layering affecting both radial and tangential cortical organization. So what does it look like on the microscope? We see here a section of normal 6-layered cortex that is stained immunohistochemically for nu-N, and in this case, this is focal cortical dysplasia type 1A. We see microcolumns of small neurons radially arranged. We don't see normal layering except for the molecular layer, and the white matter to cortex boundary is blurred because there are many heterotopic neurons in the subcortical white matter. Focal cortical dysplasia type 1B can look like this: total cortical disorganization with clusters of neurons. We even see neurons in the molecular layer, and there is a blurred cortex to white matter boundary. Focal cortical dysplasia type 2 is a cytoarchitectural dysplasia. So type 1 was just architectural abnormalities, but here in type 2 we see cytological abnormalities in the form of neuronal dysmorphism in type 2A and neuronal dysmorphism and balloon cells in type 2B. In the picture on the left, we see a normal pyramidal neuron properly oriented. The PL surface is up here, and above it we see an abnormal dysmorphic neurons with coarse cytoplasm because of the accumulation of neurofilaments, with abnormal dendrites, and other neurons, this one with a large, very large nucleus. The nucleus is almost larger as the whole pyramidal neuron down here. And this is focal cortical dysplasia 2A. So when we see only this type of neurons in the disorganized cortex and don't see these cells, it is 2A. If we see these cells, like on the right with abundant ground glass cytoplasm and eccentric nuclei, which are called balloon cells, this is focal cortical dysplasia type 2B. And this picture of dysmorphic neurons and balloon cells in a disorganized cortex in focal cortical dysplasia type 2B is identical to the histological aspect of the cortical tubers in tuberous sclerosis. So these two lesions histologically look identical. Macroscopically, we can appreciate the lesion of focal cortical dysplasia type 2B. This is the lesion we saw on the previous picture on the right. So here on the right, we have abnormal cortex that is thickened, that is pale, and without a sharp border to the white matter like the adjacent gyri in the same case. Focal cortical dysplasia type 3 is cortical dysplasia associated with the principal lesion. So this is a new category introduced by International League Against Epilepsy. And it has 4 subtypes. 3A is cortical dysplasia associated with hippocampal sclerosis. 3B, cortical dysplasia associated adjacent to a glioneuronal tumor. 3C is cortical dysplasia adjacent to vascular malformation. And 3D is cortical lamination abnormalities adjacent to any other lesion acquired during early life, like trauma, ischemic injury, encephalitis. In our series of 167 patients in a 10-year period, 29 were diagnosed with focal cortical dysplasia. And the most common type was like almost half of cases were focal cortical dysplasia type 3, so associated with some other lesion. Most often it was hippocampal sclerosis, and some were associated with tumors. Well, tumors are the common cause of epilepsy, so it's very widely known. And they are the cause of epilepsy in 4% of all patients that have seizures. But if the epilepsy has an early onset before 25 years of life, they are the cause in 15% of cases. In patients that have a brain tumor, over 40% have epileptic seizures, and over 75% of those who have a low-grade tumor. So we differentiated 2 groups of patients in which brain tumor is the cause of epilepsy. Older patients with a malignant tumor that usually have a neurological deficit, and children and adolescents, younger patients with a benign tumor that usually don't have a neurological deficit. In the second group, epilepsy is early onset, long duration, often pharmacoresistant, and caused by slowly growing low-grade glial or glioneuronal tumors. And we come to the concept of LIET. This group of tumors were called long-term epilepsy-associated tumors. As patients with these tumors are now more often operated and cured early, the acronym now stands for low-grade epilepsy-associated tumors, because their epilepsy is not anymore of long duration. So epileptogenic tumors have some common characteristics. They are rare, very rare tumors. They are benign, usually WHO grade 1. They are slow in growth and have a very low risk of malignant progression. They are mostly neuronal and mixed glioneuronal tumors with a predilection for the temporal lobe. And some, as we said, are associated with focal cortical dysplasia, the focal cortical dysplasia type 3B by the ILE classification. These tumors are most often the entities we see on this list. The histopathological characteristics of these tumors are beyond the scope of this presentation, and there is just no time to present them all. Just to say that ganglioglioma is the most common, by far most common of these tumors, but also we see dysembryoplastic neuroepithelial tumors, angiocentric glioma, papillary glioneuronal tumors, multinodular vacuolating neuronal tumors, isomorphic diffuse glioma. And in our series of 167 patients operated in a 10-year period, 33, almost 20%, were diagnosed with a tumor, and as expected, the most of them were gangliogliomas, 21, almost 2/3 were gangliogliomas, with 7 DNTs, 1 angiocentric glioma, 2 diffuse gliomas, a meningioma, and a multicentric vacuolating neuronal tumor. In conclusion, we see that hippocampal sclerosis is the single most common cause of surgically treated focal pharmacoresistant epilepsy. Hippocampal sclerosis with cortical dysplasia and tumors isolated or associated in dual pathology together make almost 90% of all causes of focal pharmacoresistant epilepsy in our series. And if you have a patient with a long-standing epilepsy that is lesional, that is amenable for surgical resection, it is most probable that his lesion will be one of these 4 lesions in the top of the table. Thank you very much for your attention.
Спасибо, Сава. Я думаю, что
Thank you very much, Sava. I believe we'll ask our questions in September at one more Russian-Serbian symposium dedicated to neurosurgery only. The next presentation is from Emilia Manailovic. She's also from Belgrade, and it's named Difficulties for Morphological Diagnosis of a Tumor of the Central Nervous System. Is she on air? We expect her to broadcast.
Emilija, ne čuješ se?
у нас там какие-то неполадки.
Hello. Can you hear me now? Hello? Oh, finally.
Hello, Emilia.
I'm so sorry. Oh. So, do you see my presentation?
Yes, yes.
Oh, thank God. So, dobry den, my dear colleagues. Dear chairman and dear colleagues, I'm pleased and very honored to take a part of this wonderful and special Russian-Serbian symposium. I'm very grateful for the invitation, and I would like especially to thank to my dear colleague Lyubov Mitrofanova, who invited me and who initiated this wonderful collaboration. Excuse me, I just have to remove speakers because I hear translator. Is it okay? Can you hear me like this?
Yes, yes.
Yes, we can hear you.
Okay, thank you. So, the topic of my presentation will be morphologically challenging tumors of the central nervous system. As we all know, the last classification of tumors of the central nervous system was published by World Health Organization in 2016. To the best of my knowledge, new publication will be published during this year. This new publication of tumors of the central nervous system will be based upon the consortium to inform molecular and practical approaches to central nervous system taxonomy. We all know that this concept, See Impact Now, published 6 publications, and they were related to different kinds of diffuse glioma, including IDH1 positive and IDH1 negative, then pediatric gliomas, ependymomas, and also they were related to tumor taxonomy. Diagnostic algorithms for both adult and pediatric glioma became very complicated, and numerous molecular data are included now in the diagnostic procedure. They're very numerous, so I'm asking you just to pay attention to cyclin-dependent kinase 2A and B, because it will be important for the rest of our lesson. Contemporary diagnosis of pediatric glioma also became very complicated, and contemporary diagnosis of diffuse pediatric glioma depends upon numerous molecular analysis. Majority of them are related to possible therapeutical options. Today, I'm going to present you a case of a tumor of 13-year-old boy. He had a large supratentorial tumor in the left frontal region. He underwent neurosurgery and he had maximal tumor reduction. After that, we tried to establish precise morphological diagnosis. The first morphological impression was that tumor had a lobular growth pattern. And this lobular growth pattern was even more pronounced in higher magnification. There were also areas of diffuse growth pattern, and in those areas we could see microvascular proliferation. We all know that microvascular proliferation is a sign of a high-grade tumor. We also observed some areas with branching capillaries, like this or like this. We also observed foci of necrosis, which were surrounded by pseudopalisades of tumor cells. We also know that necrosis, which is surrounded by pseudopalisades of tumor cells, is also a sign of high-grade tumor. So we were sure that we were dealing with a high-grade tumor. Now let's move to morphology of cells. So, majority of cells had rounded dark nuclei and perinuclear halos. They had so-called fried egg appearance or oligodendroglial-like appearance. Nuclear atypia was very pronounced in some area. So, after hematoxylin eosin examination, we were sure that we were dealing with a high-grade tumor, but we wanted to recognize the origin of the tumor. Is it neuronal tumor or glial tumor? Differential diagnosis of tumors with fried egg or oligodendroglial-like morphology were oligodendroglioma, then clear cell ependymoma, then central neurocytoma. They were the main differential diagnosis. And that's why we started our immunohistochemical investigation with the basic marker vimentin, and tumor cells were negative. And we also had a very intensive internal positive control. And we applied glial markers. First, we applied basic glial marker S100, and tumor cells were negative for S100. Then we applied glial fibrillary acidic protein, or GFAP, and we observed scattered tumor cells that were positive. And we also observed reactive astrocytes that were positive, but here all tumor cells were negative for GFAP. So we had, let's say, negativity for two basicals which were positive for NEO-N. Then we applied neurofilament and we saw that all tumor cells were negative with internal positive control. For the end, we applied MAP2. We know that MAP2 was primarily discovered as neuronal marker, but later we realized that MAP2 could be also positive in some glial tumors. So MAP2 was diffusely and intensively positive. Then we applied epithelial membrane antigen and the staining was absolutely negative. Epithelial membrane antigen was applied in order to exclude ependymal differentiation. We also applied INI1 in order to exclude the possibility of atypical teratoid rhabdoid tumor. So this positivity for INI1 excluded the possibility of atypical teratoid rhabdoid tumor. P53 positivity was observed in scattered cells. And finally, we applied proliferative marker Ka67. Unfortunately, Ka67 was extremely high, more than 50%. So we were sure that we were dealing with a high-grade, aggressive, highly proliferative tumor, but we still had a dilemma regarding tumor origin. Was it glial or neuronal? Bearing in mind that this oligodendroglial-like morphology could be the sign of oligodendroglioma, we performed the analysis 1p19q deletion. This co-deletion was absent, but on the other hand, we were dealing with pediatric tumor. So the absence of this co-deletion 1p19q doesn't mean that this tumor could not be oligodendroglioma or just glioma. So after days and weeks of discussion, we decided that this tumor could be supratentorial embryonal tumor. So, patient underwent radiation therapy. Unfortunately, tumor recurred despite the initial subtotal resection and radiation treatment. On the other hand, we were very transparent with boys' parents, and parents knew about our dilemma regarding the origin of tumor. And that's why parents initiated multiple second opinions in numerous centers outside the Serbia. And believe it or not, numerous experts in neuropathology from Western Europe had the same conclusion as we had. They were not sure regarding the origin of the tumor. Was it glial or neuronal? Tumor grew up and the second surgery was performed 1 year later, but second surgery was performed in other center. It was performed in the United States, and fresh tissue was taken from that surgery in order to perform UCSF500 cancer gene test. This test is capture-based next-generation sequencing, which targets and analyzes coding regions of 479 cancer genes. So the aim of this test was to try to recognize the origin of tumor. And here is what this test found. First of all, this test reveals a very unique and peculiar mutation called ZNF217. The name of this mutation is not so important. It is important that this mutation was seen for the first time in any brain tumor. And that's why we couldn't know the significance of this mutation, and that's why this somatic alteration of unknown significance. On the other hand, two another mutations were discovered, and both of them were advocating glial origin of this tumor, but on two different ways. The first mutation, it wasn't exactly mutation, it was homozygous deletion of Cyclin-Dependent Kinase N2, A and B. I paid your attention on the algorithm, and I asked you to remember this homozygous deletion, because this homozygous deletion is a sign of adult glioma. So this homozygous deletion is typical for adult diffuse high-grade gliomas. On the other hand, this test also revealed so-called NTRK2, or NTRK, we call it like this, structural rearrangement, which is typical for pediatric gliomas. So this NTRK2 structural rearrangement is typical for pediatric glioblastoma, but also for pediatric pilocytic astrocytoma and the pleomorphic xanthoastrocytoma. So we had two signs of glial differentiation, one of them being for adult and another being for pediatric gliomas. You must be asking yourself if this test was analyzing numerous mutations that were characteristic for pediatric glioma. And the answer is yes. So those mutations were all analyzed. This is the list of all mutations that were analyzed, and all the genes that are needed for contemporary diagnosis of pediatric diffuse gliomas were negative. So all those mutations were negative. Additionally, the possibility of microsatellite instability was excluded. Then, there was no evidence for atypical teratoid rhabdoid tumor. There was no evidence, genetic evidence, for embryonal tumor with multilayered rosettes. There were also no evidences, molecular evidences for medulloblastomas, and there were no also genetic evidences for other embryonal tumor subtypes. So, for the conclusion, we could say that we were dealing with a definitely glial tumor with both adult and pediatric genetic features. And we can ask ourselves, where is the age cutoff for pediatric and adult tumors? So we must keep in mind that the use of molecular biology techniques is not available in every center. So sometimes we are dealing with the problem which genetic panel to apply for pediatric tumor or adult tumor. Or we can think about those children who are teenagers, who are having aggressive and malignant tumors, and obviously their tumors can harbor both genetic characteristic, adult and pediatric. So, significance of genetic investigations is great, and they're very helpful, but unfortunately in this case, genetic investigations could only give us the information regarding the origin of tumor, and they could not help us to precisely specify the type of the tumor. Thank you for your attention.
Emilia, Спасибо за очень интересный случай.
Dear Emily, thank you very much for this interesting case. I got a question. Do you use sequencing in your center?
Not, still not.
Да, и вот у нас сейчас
And in Russia, we hear about the possibility of purchasing this equipment, sequencing machines. And in Moscow, our colleagues use one of these methodologies because it's really high-priced and expensive. So we hope that it will be implemented firstly for treatment of children. And are there other questions, colleagues? Dear Emily, I got a question. How often do you use immune histological research for brain tumors, for microhistology?
And are you asking me for the immunohistochemistry on micro instability?
Ага.
How frequently in your presentation, you mentioned the microsatellite instability. How frequently in your center do you use immunohistochemistry to diagnose the macrosatellite instability for the brain tumors?
Fortunately, we do not analyze microsatellite instability. This analysis was performed in Washington together with this NGS analysis. In our center, we can apply only immunohistochemistry. We can apply fluorescence in situ hybridization for detection of 1p90q. We also plan to include NGS in our diagnostic procedure, but unfortunately, we still do not have equipment for it.
Спасибо.
Thank you very much. Any questions? Emilia, in that case, I do hope, we all hope to see you in person in September, unless COVID is still an obstacle.
I really look forward to work with you personally.
Спасибо.
Thank you. The next speaker is from Danica Rusic. Danica has modified the name of her presentation, but she will in general describe glioblastomas. Can you hear me? I can't share my screen, unfortunately. Emilia has to exit for me to enter, I believe.
Емилија, изади из екрана, немој да шеруваш твој екран. Емилија, немој да шеруваш твој екран. Изаđи, пошто се још увек види твоја презентација. Не, I'm sorry. Емилија, склони твој екран из... Тако е. Ја попробую поделиться екраном.
I will try to share my screen, but somehow I failed to do it. Don't know why. I still see Emily's presentation on the screen. So do we. Can Emily's presentation be removed? Not yet. I don't know why. Can you see my presentation? Now we can. So I'll begin. First of all, I'd like to thank you for this chance to speak in Russian after a 40-year pause. Happy to speak Russian with my Russian colleagues, and I'll share the experience of neuroblastoma treatment in the neurosurgery clinic in Belgrade. Can tell about our hospital. We have 150 beds, and we deal with neurosurgery pathologies only. The most frequent tumors are glioblastomas. That's the latest classification from the year 2016. I won't describe it in detail, though. I'd like to say that, like all the colleagues, the glioblastomas we encounter in younger patients with IDH positive tests. The result of the treatment is better. Some other centers in Serbia do the treatment as well. This is the study conducted between the years 10 and 12. 110 patients, some of them still live, though they really had glioblastomas. The study included 110 patients, 40% were female, 60 male. This is the age distribution. Like in other cases, the most frequent age group was between 51 and 60. Next biggest group was between the age 61 and 70. However, we had many young patients aged from 20 to 40. Unfortunately, and lately we get a lot of children with glioblastomas, not only in the brain stem, but in the other parts of central nervous system as well. These are the status groups, and let's continue. Our analysis proved that survival does depend on the age. It is a prognostic factor for these patients' survival and for the performance-free for the patients who have no relapse of tumor symptom. As for the youngest groups, the average survival was up to 38 months, because they were usually IDH positive. We always try to do our best when performing the surgery so that it's as radical as possible, whether it's in the temporal part of lobe of brain or in the front part of the brain, but it's not always that we can do radical surgery. We are not always able to do it, to have the radical resection. Level 2 of evidence proves that the total or radical resection really helps such patients to live longer. And another practical thing mentioned by the colleague in the beginning of this session, T1 MRI hyperincident area really has a lot of tumor cells. Supramarginal sex in eloquent zones, there's the motor zones there, it's practically impossible. There's no clear evidence that supramarginal resection of high-grade gliomas is better, that it improves the survival of the patients. However, if possible, we should always try to do it this way. Now, here comes the question, how far should we go? What should be the margin of the resection? We should do as much as possible to improve the quality of life of our patients. for the radical resection to be safe and reliable, we frequently do the intraoperative neuromonitoring. We control the motor functions of the other limb of the controversial limb. And if possible, if the patient can commute with us, we do the awake surgery. What we do not do, unfortunately, is 5-LI intraoperative MRI. Let me tell you something else. And the other point, when the patient can contact and talk to us and carry out certain tasks, this doesn't seem to be a good practice for the treatment of high-grade glioma and glioblastoma. It's only a good method for low-grade tumor, because we sometimes had very big complications during the surgery if those were the glioblastomas and not astrocytomas of degree 2 and similar ones. This is just a resection. That's the way the surgery goes on. The basic factors of survival, independent ones, that's the performance status of the patient and the age, scores from 0 to 4. If a patient had a score 0 or 1, they had better forecast. And the level of radicality of surgery was of importance for survival. And it was of importance for the later relapse. When we do surgery, we should consider complications as well. That's one of our patients, male, aged 40. He had seizures and epileptic status 4 hours after the surgery. That's the first CT that envisaged the post-surgery modifications, nothing else. But 12 hours later, we found a hemorrhage on that spot. The first control CT shouldn't be the last one. It's better to continue, especially if the condition of the patient isn't satisfactory. Localization, temporal, frontal, and we had quite a number of multicentric glioblastomas as well. Sometimes we get such an image. If you see just the surface, you may think it's a butterfly shape, but in this case, that was a wrong diagnosis. We did the elemental scanners, and it was 30 by 30. So the cognitive and psychological functions of this guy were really preserved, and we dared to do the surgery. There were several surgeries since the year 13. He's still alive, though the tumor does progress. He was treated with avamostin and temozolomab, but only the radiotherapy seemed to be efficient. We did it twice. One more patient, older one. Take a look. It seems to be a butterfly, but again, minimal scallop proved that the psychological functions are preserved. We dared to do the surgery. Everything was fine after the surgery. If we have such a visualization, we dare to do it unilaterally. If we are late to remove the tumor on the opposite side, then we do the bifrontal craniotomy, or the second surgery is performed. That's the post-surgery CT of the patient. If we have the insular glioblastoma, that's a very complex structure in the depth of Sylvian fissure. It's covered with frontal, temporal, and parietal operculum, and it's very close to the white matter of the brain, and it's close to its tract and to the vessels. So if it's a low-grade glioma, it's a difficult thing, but if it's a high-grade like a glioblastoma, sometimes the neurology of the patient after the surgery gets worse. We're using two techniques, transopercular after craniotomy. If we find there's no fissure and there's no distinct tumor, and transsylvian. Then we use the transopercular. Transsylvian is used if after craniotomy we open the brain, and right on the surface of gray matter we see the tumor that separates the temporal lobe from the frontal. But sometimes we manage to do the radical dissection, sometimes not. In this case, we failed. That's a 40-year-old male with psychoorganic syndromes, raised intracranial pressure, frontal and temporal transopercular approach was used for him. So radical surgery did work with him. If you see the T2, most likely tumor cells are left over there. Hence, he does need the radiotherapy and the chemotherapy as well. Another patient, female, 45 years old. Initially, she had mild right-sided hemiparesis and dysphagia. That's what we managed to do. Radical dissection turned out to be possible. After the well, we had the approach from the most superficial side, especially after that we did the surgery. I'll try to start the movie. I guess you can see this movie. I will run it faster. Now we are opening. Well, definitely, after bipolar diatomia, the best assistance to the surgeon is the aspiration. Radical surgery in this region is next to impossible without it. When I think about the time when I did it without that assistance, I don't want it to remember it was that difficult. That's the brain artery, that's the tumor. Unfortunately, it turned out to be glioblastoma, and for this patient, I managed to do the radical dissection. That's it. One has to be very careful when making manipulations next to the blood vessels. My surgeons, neurosurgeons, my colleagues neurosurgeons know that very well. So I won't continue this video. That's the result, the CT after the surgery. Unfortunately, blastoma is not only a tumor, it's the disease of brain, and just surgery alone can't resolve the problem of our patients, though surgery gets improving all the time. I quite agree with my colleague, Mr. Gulaev, that if you're dealing with neuroblastoma patients, they will live longer if you do try to assist them. That's really true. Sometimes glioblastomas look this way. We call it gliomatosis cerebri. According to the WHO classification from the year 16, gliomatosis do not exist, but they do. Thus, what we do is just gliopsy, and radio and chemotherapy is added to assist. Now, the multicentric glioblastomas, they usually have very fast progression, and if possible, in this case, it was possible to do the surgery of both lesions. Sometimes it's impossible, so we make 2 or 3 separate surgeries. That depends on the age of the patient and on the condition of the patient. In a series of 110 glioblastomas, the surgery mortality was 2.7%. That's the number that didn't survive the surgery. Same condition as before the surgery without changes was 55.5 patients, including neurology. 31% of patients had improvement, and 12 had the worsening of neurological status. MGT was done to 56% of patients. 45% were methylated. That's a bit more than in the other series. The survival rate was better in such patients. Methylated, 22 months, unmethylated, 15 months of survival after the surgery. Oncology treatment. Radiotherapy, 60 gray 30 fractions, that is standard treatment. 16% received BCNU, that's group A. 76% were treated with temozolomide, that's group B. And 7.3 patients had no chemotherapy due to the fact that their condition didn't let them get chemotherapy after radiotherapy. That's the pseudoprogression. I'd like to mention it. We sometimes observe it. This is an MRI made 4 weeks after the surgery. It looks like a progression. However, the patient had no complaints, and in 2 months, yet another CT was made after the radiotherapy. The CT looked like that. Seems like it is a progression. We did nothing, just gave a bit of Bisazone. And after the corticosteroid therapy, you see you observe the absolute regression of this edema. What's to be done with patients that have a progression? They have the relapse. If we believe that we want to worsen the neurology of the patient, if it's okay, we do the surgery, sometimes 5 surgeries, and such patients live longer. Here are the results. Mean PFS before the relapse demonstration was 9 months in our patients. 69% had progression-free survival for 6 months, and 35.8% had the progression-free survival of 12 months. 17% had a longer period. Also, I'd like to mention that some 8 or 9 patients, 6.5%, are still alive. That's a 10-year survival. They had surgery yet in the year 10, 11, or 12. It's quite a good result, I believe, and it's achieved thanks to the fact that if the focus or loci of the tumor was small, we still did do the surgery. It's not an easy kind of a surgery. However, we achieved quite a good survival. 5 years, 7.3%, and 6.4% had a survival of 10 years. So I think with such patients, you need to assist them, you need to struggle for their life, treat them like children, think about them, care about them, and perhaps some of them have a chance to live longer.
Извиняюсь, я что-то напутала.
Okay, I'm confused. I'm sorry.
Извиняюсь.
I'm sorry. Just a couple of more slides.
И вот это наши результаты.
So these are our results, and in the end, I can say that
Как бы сказать, состояние его до
age is crucial here, and then condition before and after the surgery and after chemotherapy. So glioblastoma should be approached as a surgical issue, but also need to know that it's a brain disease and that surgery will not be the last stage of the treatment that should be undergone or should be performed. I'm sorry for my Russian. I haven't had the chance to speak Russian for age. You speak wonderful Russian. When I was in Moscow 40 years ago, they told me that I speak as a Ukrainian person. Your Russian is better than of a lot of our colleagues living in Russia. Question. What is your opinion? What is the timeline or time limit for therapy in patients with glioblastoma? Very often, we carry out radiotherapy on the 4th or 5th week after the surgery. Besides that, we do standard radiotherapy, and what is good for our patients. In our clinic, we have a hospice. It's a daily stay. So all chemotherapy they get in one place. They can do all the examinations, laboratory examinations, blood, and chemotherapy, radiotherapy. It's a place where they can get all services. There is a medical oncologist, our colleague who works there. She's an dermist, and she takes up neurodermia. For neuro patients, they're always connected with their surgeon. So they need to have a surgeon somewhere nearby. Even a surgeon cannot do anything very often, but an oncologist can do a lot. The first line of chemotherapy, second, third, fourth. So the patients in good condition, they live longer than before. Actually, this is this daily hospital. It's what I think it's the most important thing that we have done for our patients. They have different kinds of therapies in situ, in one place. So if they have neurological issues, we can also solve those. For glioblastomas, we do MRIs every 3 months. If they live longer than 2 or 3 years, then we do it every 4 to 6 months. And these patients who live 10 years or more than 10 years, we do MRI once a year, obligatory. Thank you very much. So to my opinion, we have spent a good day. I would like to express my gratitude to all the colleagues. It's really nice to deal with professionals, and it's always nice to communicate, to hear the colleagues' opinion, which is, I would need to say, is 100% my opinion as well. It coincides concerning the tactics, the surgery, the characteristics or particular features of the surgery that needs to be performed. Everything, it's all great. Everything that you stated here, all the reports and presentations. I think that further collaboration of morphologists, neurologists, and neurosurgeons on the basis of the common knowledge and sense, and on the basis of the science will be fruitful, and I think will make a breakthrough. And will try to provide a great, better quality of life and lifespan for our patients. I'm sure that it will be the case, and I would like to officially invite you to our autumn symposium. Will be in a beautiful place in Petrodvorets, and it will be golden autumn, and fountains will operate at that time, and I will come by all means. We are going to be looking forward to seeing you, and we're not going to discuss the topics, but in a week or 2 weeks, fortnight, if I can say something else. Neurosurgeons, there are some of them that
they're dealing with neuro-oncology, and we've decided to organize a meeting in Belgrade, and we're going to invite the colleagues from the Balkan countries, but you're welcome as well. Please come and share your experience with our colleagues. We'll deal and develop the topics of our presentations later on. Thanks a lot for your invitation. Goodbye and all the best to you. Emilia, goodbye to you too. Colleagues, thanks to everybody for participation. Those participating online and offline. Thank you.